The Thompson Center service model, Dr. Farmer can speak to this to a greater level of detail than I can, but it's a multidisciplinary approach to care for the client/patient. Services are provided by our members of the departments of psychiatry, child health and subspecialty, physical medicine and rehabilitation, school of health professions with psychology, speech and occupational therapy, as well as some family resource services. Anything else, Dr. Farmer, that you'd like to add to that? I won't go through all of these, but I just wanted to share with you a list of the clinics, the various clinics that are offered in one location for the clients that access the Thompson Center for services, including the diagnostic, medical, neuropsychology, intervention services, occupational speech, family therapy, family resources. Can everyone hear well enough so far? Is it working? No? Okay, I'm going to try to shout. The total number of children seen in fiscal year 11, almost 2,400 in total, with 10,000 in visits in fiscal year 11. Our contracting targets, as we were working to support the House Bill 1311, we looked at behavioral health plans that covered state, public, and university employees. And the reason being, those were the largest populations that were impacted by this legislation. So we're looking to cover the largest number of lives that we possibly could with these agreements. And we also went after some of the larger commercial plans that had agreements that also included provisions for the behavioral health services. Our timeline was fairly aggressive in that House Bill 1311 became effective in January of this year. In March of 2011, negotiations with the payers were initiated. And I would have to say between January and when the negotiations initiated in March, there was a significant learning curve, a steep learning process, as those of us from the business aspect and the contracting aspect really had to learn what ABA services were, understand the new licensures and designations. And I thank the Thompson Center, Dr. Farmer, and her staff for helping us with the 50 million questions that we peppered them with as we worked through the process in negotiating with the payers. It was all brand new to us. By April, we had contracts and/or letters of agreement in place. So the contracting process, once it was in motion, went very quickly, faster than most instances that we see on the medical side. So the payers were coming to the table and willing to work with us to get this done. We were trying to obviously get covered as soon as possible to take advantage of the coverage under the House bill. By June of 2011, we started billing commercial payers. And I'm looking now at, boy, it's been 6 months and we're still learning about the process as we go. Our agreements currently are with United Behavioral Health, and we chose United Behavioral Health because they are the mental health carve-out for United Health Plan as well as UMR, and they cover the state employees. In 2011, they covered the university-covered lives as well. MHNet Behavioral Health. MHNet is the carve-out mental health plan for Coventry and GHP. As well as Healthcare USA, we have an arrangement with them. MHNet will be covering university employees as of January 2012, so that represents a significant population between UBH and MHNet. That is a significant, what we anticipate is a significant piece of the population that will have access to this benefit. In addition, we contracted with Anthem and HealthLink because they're some of the larger commercial payers in our network, and they have the behavioral health aspects integrated into our agreements. The Tri-West agreement had existed. This isn't new. It wasn't new with the legislation. It was part of a demonstration project, but because it is an existing agreement, I added it here. As we began talking to payers, it was clear that we weren't always talking apples to apples, and the reason for that is that we were finding that there was a lack of standard in process working with various payers, and I think a lot of that can be attributed to the fact that payers, some of these payers had experience already in the few states that currently recognize and cover ABA services. And these payers were trying to use their existing process in the state of Missouri, and therefore some of their processes, their codings and structures were different than what we were experiencing with other payers that were just starting here in the state of Missouri. For example, as we work with payers, there is at least one payer that recognized Thompson Center as an agency, both for credentialing purposes and for billing purposes. In our worlds, we're used to, we have 600 billing providers for university physicians. We enroll each one of them individually. They each submit medical claims under their own names and numbers in the medical world. This particular payer wanted to recognize and see claims from the Thompson Center only under the agency's name. Because of this, the billing process is different, but on the front end, the credentialing process was significantly different. Because the payer is classified as an agency, they required an extensive facility application, a site audit. It was, 20 pages, a quarter of an inch thick. We spent a lot of time working on getting all of their answers and going through the reviews and audits. That's different than what we're used to. We're a JCO accredited organization, and typically that gives us a pass. We don't go through the individual site audits with particular payers. So that was something new for us, something that we had to deal with. Well, that was one payer, and we have other payers that we've contracted with that have followed with the existing model where they are individually recognizing, credentialing, and enrolling BCBAs and the assistant BCBAs, et cetera. So they're looking at the individual level, they're enrolling and credentialing at the individual level. So we're seeing a difference in how payers are approaching this. Another difference in standard is the role of the assistant BCBA, the BC_ABA, in that most of the payers recognize them as separate providers that can provide direct services. There is one provider that interpreted the state law to define them and couple them in reimbursement and in the types of services that they can render as line therapists. So we're seeing within the payer mix that the recognition of the licensure still it varies a bit. In addition to that, and something that really threw me in the contracting process, obviously you want to understand the services that you're expressing to a payer and knowing what you're negotiating a rate for. Payers were classifying the services in a different manner. We have 5 contracts and I think 3 different ways that payers are classifying the 5 basic categories of services that are rendered. So we have the assessment and treatment planning, you have the direct services by the BCBA, you have the supervision services of the line therapist services, as well as the group therapy. So basically 5 classifications of service rendered, and payers differ in how they recognize those, both in coding units and the modifiers to identify the licensure of the provider rendering. I developed this crosswalk. Can you all see it kind of, sort of? What I was trying to illustrate here is for one single service, and I used the direct ABA services, that the 5 payers in the second column from the left, you'll see that there's a CPT or a HCPC code, and that differs from payer to payer. The descriptions of the services vary a little bit. What I tried to do is insert the description that the payer provided us. The time units, whether the service is billed in 15-minute units or an hour, vary from payer to payer. And then the licensures that are recognized as being allowed to provide a service varied a bit as well. What I tried to denote in the lighter color in the grid on the far right-hand side is if it's light green, the payer indicates, yes, that provider is recognized and billable for this service. And in the gray, the provider is not recognized as being able to provide that level of service. I created for my own purposes so that I could be comparing rates, apples to apples, for a service, and so that I could communicate to our billing department this sort of matrix. I created a grid for myself, and it's in your packets. The issue is that the color didn't show up, so that you can't see my light green and my gray. So as Mamie produces and puts out for everyone electronically a version, hopefully this will be a more useful tool for you. As you look at this grid, it's our best understanding of the payer's classification, both of the time units, their procedure coding, the modifiers some payers recognize and some don't. This is sort of our little go-to sheet as we're trying to understand how we are to bill each payer and to roll up so that we can compare reimbursement from one payer to another using some sort of a common denominator. Does that all make sense? So you can see in this example that the BC little ABA is not recognized as being able to provide direct ABA services, at least for the one payer that's denoted. I surely hope as the coverage and as this all develops and matures that there are some national standards that eventually are established, because it certainly would help to facilitate both the coding for the units and modifiers for us to be able to rate set from a business perspective, for us to be able to run some productivity reporting so that we can be aggregating apples and comparing those against the oranges. Where here we have to do a lot of sort of back translation tables to get at the data that we're trying to analyze. And it certainly would simplify the billing process. We have a general intake, and Dr. Former's team will show you this. We tried to take the generic set of state recommended codes. That's what's used as a client/patient is seen. And then we've got folks behind the scenes that are actually taking that intake form, translating it using the grid to be able to prepare a claim form that goes out into the insurance plan in the language that they speak. So there's an awful lot of translation that's going on. It is time-consuming. If volumes were greater, this would become a laborious process, and it's complicated. So I'm hoping that on a go-forward, perhaps there'll be some more standardization of the revenue capture, the service identification. In addition, the role of the BC little ABA, I think, could use a little bit more definition, especially when you're trying to staff and you're trying to manage a patient and understand how you can use a BC little ABA. In the care, I think that's a bit of a challenge that could use some more development as well. We had to develop some new processes at the university. We typically have delegated credentialing, which means that when a billing provider joins us, they go through our medical staff process, and we validate licensures, background, education, criminal background, et cetera, et cetera. We go through and vet the provider. When the provider is fully credentialed, and only then is when we enroll a provider as a billable provider with a payer. Our med staff office wasn't familiar with the licensures. They had to develop a different process for board, validating the board certification and the licensures. So that was a step in our process that we had to develop. It's working nicely now, thank you. The line therapist, state law requires that the line therapist is only billed under a supervising PCBA. At least one of our payers interpreted that and said, in order for you to contract with us, you have to assure us that you have an employment agreement with all of the line therapists that they use. That was a change, because in the past, line therapists came from the Boone Family Resources Center or other agencies, and they weren't under any kind of direct employment agreement with the university. So that's been a significant change in process. Thompson Center is actually working on a process to employ these implementers. So initial outcomes, the agreements were completed fairly quickly. We've all learned a lot along the way. I think that the BCBAs and the clinicians at the Thompson Center have learned a little bit more than they probably wanted to know about the business aspect of things. And we've learned a whole lot about autism and ABA services. We've experienced what were surprisingly small volumes of commercially insured clients taking advantage of the insurance benefit to date, which was a little bit of a surprise in the beginning. I think that you folks here might talk about that in a little more detail. The volumes are increasing, but beginning Again, national standard